Hello, everyone. Welcome to my YouTube channel, Holistic Palliative and Pain. Our topic today is head and neck cancer in pain management and palliative care. Cancer may have knocked me down, but I'm back on my feet and I'm stronger. This is a quote from one of the head and neck cancer survivors. Objectives of the presentation: introduction, relevant pathophysiology and prognosis, physical symptoms and treatment strategies, psychological symptoms and treatment strategies, end of life decisions, and will conclude with key learning points. This is just an infogram about head and neck cancer, with the risk factors being tobacco use, alcohol use, exposure to human papillomavirus or HPV, persistent neck mass or pain in the mouth, throat. Men are affected with head and neck cancer more than women, are in a ratio of 4-1. Early diagnosis can more than double a patient's chances for survival. Some of the early signs and symptoms are a red or white spot in your mouth that doesn't heal or increase in size, change in your voice that lasts more than 2 weeks, sore throat, swollen tonsil or difficulty swallowing, a lump in your neck. In 2018, 650,000 new cases of oral head and neck cancers worldwide were diagnosed. Introduction. The term head and neck cancer encompasses a diverse group of cancers that includes cancers of the skin, oral cavity, larynx, skull base, trachea, jaw, thyroid, and sinuses. Based on the data from National Surveillance Epidemiology and End Results, or they call it SEER, database from 2013 to 2017, the median age of diagnosis is 63 years. And this group of cancers is more common in males than females, as we mentioned before. Overall, 5 survival rates from 2010 to 2016 SEER data were 66.2%. This diagram shows you different locations of head and neck cancer. Oral cavity being the common site, 36%, followed by the larynx, 25%, then the oropharynx, 19%. Tumor burden. Because of the tumor burden or side effects of the cancer treatments, patient may have difficulty with basic life daily actions such as speaking, self-expression, and eating and drinking. Head and neck cancer primarily affects the face. Thus, disfigurement can be disturbing and emotionally destabilizing. Unlike other cancers in which body alterations may be hidden, such as an amputation or colostomy, changes to the face are apparent to the public and often interfere with ability and desire to socialize. The disease trajectory is relapsing and remitting, with periods when patients are symptom-free and have no evidence of disease, interspersed with times of higher symptom burden when the disease is active. As a result, Patients with no evidence of disease may still have anxiety and concern about recurrence. Given their multiple needs, patients with head and neck cancer should receive palliative care as a core element of their oncological care, and early integration of such services is aligned with current clinical practice guidelines. Ways to prevent head and neck cancer: no smoking, maintain good oral hygiene, avoiding alcohol abuse, eating a well balanced diet, and protect yourself against human papilloma virus infection by practicing safe sex and getting the HPV vaccine. Using sunscreen, lip balm regularly. Relevant pathophysiology and prognosis. Head and neck tumors are primarily squamous cell carcinoma, and there is a strong and dose dependent relation between alcohol and tobacco consumption, as we mentioned before. Smoking and alcohol related HPV negative cases are decreasing in older adults, while more HPV positive cases are being seen in younger adults, particularly white middle aged males, likely to variations in substance use and sexual behavioral patterns in the general population. Palliative care clinicians must understand the role of HPV in head and neck cancer, as it has broad implications for clinical care. HPV has a higher proclivity for certain tissue types, and up to 60% of oropharyngeal cancers are HPV positive. HPV positivity is associated with improved response to treatment and a favorable prognosis, both at the diagnosis and at the disease recurrence. Due to these observations, the 8th edition of the tumor node and metastasis staging system establishes separate staging for HPV positive and HP negative oropharyngeal carcinomas. Staging remains unchanged for non oropharyngeal carcinoma, regardless of the HPV status. Antineoplastic treatment depends on multiple disease specific factors. Treatment can include any combination of surgery, chemotherapy, immune therapy, or radiation, and the plan often changes over time. For example, an initial plan for surgical resection alone may be modified to include adjuvant therapy if pathology reveals adverse prognostic features. Despite advances in treatment, most patients with head and neck cancer will have a disease recurrence, and recurrent or metastatic disease portends both a poor response to treatment and poor prognosis. Although palliative care specialists cannot grasp every nuance of oncological treatment, they must understand the complex landscape of antineoplastic treatments available and that the patients may be offered enrollment in the clinical trial at any time during the disease. Upstream palliative care support can help patients navigate dynamically changing treatments throughout their disease course and make decisions that are concordant with their values. Main treatment strategies in head and neck cancers are basically surgery, radiation, chemotherapy, and targeted therapy. Symptom management. These include, in particularly, pain, mucositis, dysphagia, changes in salivary function, changes in speech, dysgeusia, trismus, and psychological symptoms such as guilt, anxiety, depression, and PTSD. Pain in patients with head and neck cancer is a mix of nociceptive and neuropathic pain. Nociceptive pain is usually managed with opioids, and usually we try, non-oral approach. For example, transdermal patches, such as fentanyl or buprenorphine patches, um, and or liquid morphine via gastrostomy tube. Most of these patients, the head and neck cancer patients, they get a gastrostomy tube during the course of their treatment, and thus it's better to use the liquid morphine and patches. Despite right now we have different options. Also, using gabapentinoids for the neuropathic pain is also important in these situations. And neuropathy is a result from invasion of nerves by tumor or as a consequence of surgery and or radiation, and is optimally treated with an adjuvant analgesics. Initiation of gabapentin during radiation is associated with less opioid use, shorter duration of gastrostomy tube use, and improved swallowing outcomes. Adjuvant analgesics may help limit treatment interruptions due to pain and potentially reduce the long-term opioid use. Post-treatment pain is significant in head and neck cancer and is particularly important in patients treated with curative intent, especially at young age, who live with sequelae for decades. Approximately 15 to 40% of head and neck cancer survivors have chronic pain, many of whom report persistent pain that impacts quality of life more than 10 years after treatment. Pain management should be optimized to improve cancer treatment adherence and preserve functionality. Palliative care clinicians may not continue to be a part of the care team for patients in remission who develop chronic pain, but if needed, can assist with dose titration medications associated with long term toxicity, such as opioids. Again, to summarize the head and neck cancer pain, it's basically we focus on the type of analgesics, as we mentioned before, could be transdermal patch or morphine oral solution. Poor outcome because of anatomic distortion, sheltering, and influence of cranial nerves on swallowing and breathing. The type of pain interventions we use in head and neck cancer pain is not, like other parts of the body. Basically, we have trigeminal block, stellate for sympathetic mediated pain, and intraspinal or intrathecal drug delivery systems. Generally speaking, head and neck cancer pain is managed pharmacologically. Interventions play a very small role in head and neck cancer pain because of the above reasons that we mentioned: the anatomic distortion, sheltering, and the influence on cranial nerves, on swallowing and breathing. This is just to give you an understanding of the trigeminal ganglion block. Of course, in a trigeminal neuralgia, this makes a lot of sense. However, if you have a distortion by the tumor itself, it could be impossible to do such a block. Trigeminal neuralgia happens in cerebellopontine angle tumors. Okay, we call it secondary trigeminal neuralgia. With this block, you might have some complications such as diminished corneal reflex, masseter weakness and paralysis, dysthesia, anesthesia dolorosa, and keratitis. Stellate ganglion block still plays a role in sympathetic mediated pain, such as post-herpetic pain, for example, or a complex regional pain syndrome. We do the block at the level of C6 or C7, and usually it's accompanied with Horner syndrome, as you see in the picture, where the patient will develop meiosis, anhidrosis, and enophthalmos, plus nasal congestion from blocking the sympathetic system. Another complication or symptoms that we encounter in head and neck cancer is mucositis. It's estimated that 90% of head and neck cancer patients who undergo radiation will suffer from mucositis. Risk factors include female gender, younger age, poor oral hygiene, malnutrition, and tobacco use. Mucositis usually begins 2 weeks after radiation, and it plateaus 2 weeks after completion of the therapy, with gradual improvement over the following 8 weeks. So, because of this, tissue damage extends over a period of months. Effective management is essential to ensure mucositis doesn't interfere with the oral intake or interrupt treatment, as every day of missed radiation corresponds to a 1.4% reduction in the likelihood of local disease control. Patients should take in at least 3 liters of hydration a day to account for the insensible losses from mucositis. Those who cannot do so may require a gastrostomy tube or even parenteral nutrition to prevent dehydration or malnourishment. Weekly examinations are recommended to ensure mucositis is optimally managed and to evaluate for superinfection. These are some of non-clinically significant, methods that have been used in mucositis. Something like magic mouthwash, amifostine, chlorhexidine, benzidamine, glutamine, cryotherapy, other stuff like calendula, honey, or aloe vera, ginseng. These are kind of, camp therapies. Keratinocyte growth factor. All of these, have doubtful benefit in mucositis. Okay, next to mucositis is dysphagia and odinophagia. Dysphagia is difficulty swallowing, and odinophagia is painful swallowing. Patients with swallowing issues often require prophylactic gastrostomy tube to supplement or replace the oral intake. Here, the intent of artificial nutrition is short term with clear benefits, unlike its use near the end of life. There is no clear data on whether prophylactic or reactive feeding tube placement is best in patients with head and neck cancer, and the decision is often made based on clinician and patient preference. It is important to recommend early involvement of the interdisciplinary team, including a speech language pathologist and nutritionists. Speech language pathologists can develop a plan of action and assess patients' compliance with swallowing exercises and maneuvers, while nutritionists can help to ensure adequate intake of fluids and calories and teach techniques, example, bolus feedings to minimize the interference of artificial hydration and nutrition with quality of life. Changes in the salivary function. Changes to salivation can range from marked reduction, xerostomia, to sialorrhea, overproduction, and drooling. Xerostomia is a common result of radiotherapy induced salivary gland damage and decreased salivary production, and can lead to difficulties speaking, eating, and swallowing, increased risk of dental disease, and reduced quality of life. Unfortunately, xerostomia can be irreversible with cumulative doses of radiation, and counseling may be needed to set patients' expectations. In addition to careful mouth care, the major treatment modalities for xerostomia focus on either increasing the body's own salivary production or artificially increasing oral moisture. Examples: saliva substitutes, ice chips, or sips of water. Non pharmacologic techniques to increase saliva production include chewing gum, sucking on candies or lozenges, and even acupuncture. Though the evidence supporting each of these is weak, this is give you kind of an idea of how it looks when the patient has xerostomia. Changes in salivary function is really one of the things that can affect the quality of life of these patients. I recall a friend of mine had a major head and neck surgery uh, and that developed this xerostomia. Despite being cured from the disease, his quality of life has changed dramatically because he couldn't taste the food, after the surgery. And this is really a big issue to this patient. Okay, some of the pharmacological medications being used, such as pilocarpine, are still the mainstay of pharmacological treatment and have been shown to reduce xerostomia compared to placebo. However, these agents require scheduled use for at least 6 weeks to really get a benefit, and they have a high incidence of side effects such as flushing, dizziness, nausea, arrhythmia, weakness, and diaphoresis. In addition, xerostomia is the most severe in the most first 6 months after radiation, but often improves in the 6 to 12 months after radiation has been completed. It can be prudent to wait at least 12 months before initiating a cholinergic agent, as by that time, the degree of spontaneous recovery and benefit to burden ratio balance of using cholinergic agent can be better assessed. Sialorrhea is less common and occurs from post-surgical changes in the architecture of the oral cavity. Referral to speech language pathologist helps the patient learn techniques to better manage oral secretions. Anticholinergic medications can reduce secretions, though they have their own side effects such as constipation, urinary retention, orthostatic hypotension, and delirium. It is important to differentiate between quantity and quality of secretions. Acute radiation-induced damage to salivary gland reduces saliva production and simultaneously changes the composition of little saliva that's produced. So that's uh, becomes thick. These symptoms can be mistaken by patients and providers as excess production of normal saliva, the condition that we call sialuria. Differentiating between these two clinical scenarios influences management. The patient with thick saliva needs hydration, and the use of agents such as papaya extract, which contains enzymes that thin the secretions and makes them easier to expectorate. In this scenario, anticholinergic medications may be counterproductive by causing additional thickening of secretions, which triggers nausea and causes a mucus plug. Referral to a speech pathologist should occur at the time of the diagnosis so that they can educate patients and their families on anticipated changes, teach adaptive techniques, and prescribe rehabilitative interventions. Interventions include the use of intraoral prosthetic devices, targeted speech exercises to improve the lip range of motion, and strengthening exercises for jaw mobility. Speech pathologists also provide education for the use of assistive speaking devices, such as electrical larynx and techniques such as esophageal speech. We'll jump into another important topic, which is dysgeusia, altered speech. Um, and this is really an important, symptom, and basically is related to radiation-induced, altered in taste, which is basically dose dependent. So nearly all patients experience it by the time they receive more than 50 um, uh, gray units of radiation. Recovery speed depends on whether the tongue was partially or completely irradiated and can take up to 6 months with irradiation of the entire tongue. Management is primarily tincture of time, though zinc supplementation can be considered. Early use of zinc in patients undergoing radiation can prevent some dysgeusia, but doesn't expedite restoration of taste following completion of radiation. Clinicians must balance the potential benefits of zinc supplementation against the risk of causing copper deficiency. As you know, zinc supplementation interferes with the copper and can cause copper supplementation in the long term, and you should balance these two important minerals together. Other agents that you can use is alpha lipoic acid and also delta 9 tetrahydrocannabinol or THC has been shown to be helpful in these situations. Non-pharmacologic treatment include mouth care, dental hygiene, and withdrawal of drugs that may induce the symptoms, and dietary advice. Try to reduce the urea content in your diet, as this can help with the bitter taste of the food. Trismus or inability to open the mouth fully can occur from the tumor itself or treatment induced fibrosis or scarring. It has widespread ramification as it can make proper dental hygiene challenging and limit the oral intake, which is in extreme cases can render a patient dependent on a gastrostomy tube for life. Although the prevalence of trismus peaks around 6 months after radiation, one-third of these patients would still report trismus 3 to 10 years after treatment. If patient limits compliance with range of motion exercises, clinicians should teach patients to pre-medicate with an analgesic to improve treatment adherence. Use of a structured range of motion training program involves long-term physical functioning and is associated with fewer depressive symptoms in long-term follow-up. Um, Psychologic symptoms and treatment strategies um, include guilt, anxiety, depression, post-traumatic stress disorder, embarrassment, and social isolation. Patients with head and neck cancer are particularly susceptible to psychological conditions related to their disease. The severity of the psychologic symptoms is related to the tumor type, stage, and therapies received and can manifest in several ways. Guilt is always present because of the disease itself. It's often related to personal behaviors. For example, alcohol, tobacco consumption, or sexual activity. Patients with head and neck cancer may feel guilt and blame themselves for their disease. Recognition of the human papillomavirus positive oropharyngeal cancer as a sexually transmitted infection also has broad implications and may present with a unique set of anxieties for patients and their interpersonal relationships. Patients may face stigma that their cancer is caused by a sexually transmitted infection and may worry about transmission risk and rejection by their partner. It is important to acknowledge these feelings of guilt and self blame that may arise from diagnosis of human papillomavirus positive head and neck cancer, and to have a frank discussion regarding what's understood about the risk factors, prognosis, implications for the past and the future relationships, as well as current knowledge gaps. Head and neck cancer have some of the highest incidences of post-traumatic distress disorder, anxiety, and depression of any cancer population. Females, those with a history of tobacco and alcohol use, are most susceptible. Factors associated with worse course of anxiety and depression are younger age treatment with chemotherapy, worse quality of life ratings, and higher symptom burden. Depressive symptoms have a significant effect on determinants of rehabilitation and survival, including post treatment functional outcomes and treatment adherence. Depression is actually an independent predictor of survival. Anxiety rates are highest at the diagnosis, while depression peaks when the treatment is completed. Mood disorders persist over time with the high rates of anxiety, depression, and PTSD. In head and neck cancer patients up to 6 years after treatment completion. PTSD may be related to physical disfigurement or persistent fear of future disease recurrence. Given the frequency and the morbidity of psychiatric diagnosis, it's crucial to screen all patients and to treat accordingly. Treatment is basically consists of non-pharmacologic and pharmacologic therapies. Non-pharmacologic therapies include something like CBT or cognitive behavior therapy. And as far as pharmacological, uh, things like SSRIs and benzodiazepines are usually useful for anxiety, SSRIs for depression. Um, Benzos play a role in panic attack, more or less. Um, we don't um, like to actually combine benzos with opioids, as you guys know, because of the risk of respiratory depression. Embarrassment and social isolation is also significant in patients with head and neck cancer because of their body disfigurement. Um, and it's really important to support these patients in that aspect. They also have inability to eat and speak related to the disease, creating more social isolation. So it's really important to have the palliative care team support uh, and is beneficial to assess for body image issues and help with coping strategies. Um, Advanced care planning in head and neck cancer include nutrition, ventilation, and end of life discussions. As far as nutrition, it depends on the percutaneous endoscopic gastrostomy tubes and tracheostomy. Um, Survival in patients with relapsed metastatic squamous cell head and neck cancer is poor, as dysphagia, fatigue, dyspnea, and pain are more common symptoms. Percutaneous gastrostomy tube, what we call PEG, tracheostomy and analgesics are frequently needed for supportive care. In addition to best supportive care, palliative systemic chemotherapy can be delivered in selected patients with good performance status. So this is again the gastrostomy tube. It could be inserted radiologically. We call it reg or radiologically inserted gastrostomy. Or sometimes we do the PEG, which is basically uh, done by gastroenterologists. And sometimes it's done surgically. As far as the tracheostomy, usually done by ENT physicians, and basically the the whole purpose is to help with ventilation while getting your therapies. End of life decisions. Given the relapsing nature of head and neck cancer, it can be difficult to determine when the patients are near the end of life. Thus, the focus should be on continual evaluation of goals of care and benefits and burdens of treatments. If patients and families desire prognostic information, clinicians should share this as it can be instrumental for making value informed shared treatment decision. A study reviewing hospice enrollment in privately insured head and neck cancer patients showed that only 3.5% were enrolled in hospice prior to death. Of those, 21% spent 3 days or fewer in hospice prior to death, uh, suggestive of intensive use of healthcare near the end of life. Involving palliative care at the diagnosis allows the team to build rapport early and to later facilitate hospice enrollment if one aligned with patients' goals. Specific issues that head and neck cancer patients face near the end of life include pain, anxiety, oral care, dysphagia, airway obstruction, and communication barriers. On top of that, complex care of bleeding, fungating, or fistula forming wounds. Disfiguring or malodorous wounds can lead to embarrassment and impair social interactions. Bandages help with drainage and visibility, and topical metronidazole can decrease odor, though the evidence for this is limited. End of life symptoms for head and neck cancer patients are physically, psychologically, and socially distressing. Ongoing interdisciplinary team involvement is critical to address patients' complex needs and to avoid feelings of abandonment close to the end of life. Although artificial hydration and nutrition can be vital early in the disease course, the benefit to burden ratio changes in late stage disease. The declining benefits of this intervention should be clearly explained so that the patients and families understand that was once medically indicated may not be helpful anymore, especially as patients are no longer able to control the secretions and may experience aspiration. Some of the most dreaded complications are the airway obstruction and carotid artery rupture. These carry high mortality, and counseling about expectations and availability of supportive care is critical for patients and families. While palliative interventions may be available on a case by case basis, the uncertain timing of these complications and the risk of any given procedure may render them impractical. In cases where these complications are probable, palliative sedation is an important facility. In an inpatient facility may be indicated. The unique nature of the interdisciplinary team. The interdisciplinary team for patients with head and neck cancers include many clinicians who are not typically represented in the palliative care team. Head and neck cancer patients have a complex disease-directed treatment and significant physical and psychosocial symptoms. It is impossible for one specialist to meet every need of these patients and their families, and a collaborative interdisciplinary team is critical to provide high-quality care to these patients throughout the continuum of the illness. Okay, we'll conclude with a quiz here. A 59-year-old male just completed radiation therapy for treatment of his base of tongue cancer. He now complains of dry mouth and difficulty chewing food, swallowing, and speaking. He finds this dry mouth is one of the most unremitting symptoms. He asks you what can be done for this problem. You recommend which of the following? A is reviewing his medication list for possible anticholinergic, antihistaminic, or other classes of drugs that may worsen dry mouth. Regular oral hygiene with regular brushing of the teeth, with fluoride toothpaste to reduce caries and periodontal disease. C. Supplement oral moisture, regular sips of fluid, ice chips, popsicles, sugarless gum, or sucking on a sugar-free candy. Answer D is all of the above. The correct answer is D. Xerostomia is a complex, challenging problem that's underestimated by the clinician but often mentioned by the patient. Many causes contribute to dry mouth, include medications, radiation therapy, systemic diseases that decrease saliva flow, dehydration, and mouth breathing. Medications such as pilocarpine offer moderate benefit, but their use raises concerns for glaucoma, cardiac side effects, increased sweating, lacrimation, and dizziness. Often, the most benefit can be achieved using simple strategies such as oral hydration, hygiene, and minimizing drugs that can contribute to this problem. These are concluding key learning points. Patients with head and neck cancer have complex care needs, regardless of the tumor type, treatments administered, or intent of the disease directed therapy. The team should collaborate to control symptoms and provide the support needed to optimize quality of life. Thank you.